Good day, dear students. I'm glad to meet you again at my lecture. Today's topic is biochemistry of blood. At first, let's make a definition. What about we will talk? Blood is a liquid and mobile connective tissue of internal environment of our body. It is circulating in blood vessels that are connected with the central pump, our heart, and supply us with all necessary substances. Blood contains of plasma and cells, erythrocytes, leukocytes, and thrombocytes. Let's look what components we will see in blood, and then we'll talk about them more detailedly. Cellular elements, it's nearly 45% of volume of our body, and they are represented by red blood cells, the main function of which is the transport of oxygen and carbon dioxide a little bit. Leukocytes, which function is defense and our immunity. Between them, you know, from the histology, we have different streams of neutrophils, eosinophils, monocytes, and lymphocytes. And platelets, the main function of which is blood clotting. The functions of the cells you discussed in histology, physiology, and pathophysiology. So today we will be more concentrated on the plasma. But of course, we need to discuss respiratory function of erythrocytes because it is bound with the regulative system, with pH maintenance, and this is biochemistry. Plasma, nearly 55% of the volume of blood, is represented mainly by water. But we all know that blood is thicker than water. Many salts are sold in our plasma, many of them sodium, potassium, calcium, magnesium, chloride, and bicarbonate. They perform very important function. It's a part of osmotic pressure and part of very important regulative systems. Osmotic balance, pH buffer, working, and nerve and muscles functions are bound to the constant concentration of each of these elements. And we have many regulative systems that are necessary to maintain this balance. Plasma proteins, very interesting molecules necessary for us that answer for the osmotic balance. I remind you that part of osmotic pressure that is supplied by plasma proteins is named oncotic pressure. pH buffering is also their functions. It's general function. And many of proteins perform also specific function characterized for them. A part of these proteins we will discuss later today in the lecture. Fibrinogen, for example, specified for blood clotting, and immunoglobulins, antibodies, which must perform immune functions, and about structure and functioning of which you told with Professor Ifetov in the previous lecture. And of course, in the plasma, there are specific concentration of transported by blood nutrients like glucose, fatty acids, vitamins, amino acids, and these products of metabolism like urea, ammonia, uric acid. Also hormones present. Part of them are proteins, part of them are oligopeptides or derivatives of amino acids, part of them are steroids and transported with the help of specified for these proteins. So, blood is not only our internal tissue. It's easily available material useful for future various assays and measurements. It's a good reflection of diseases and injury that we have in our body. And as doctors, we must know about this and know what we must see at norm and how the different values in our blood are changed during pathology. A life-saving medicine, an infective agent. Also, don't forget about them, about transmissive diseases. This is material for investigation in science, and of course, economic factor, because it can save the life and it can brought a death. So it needs to control the blood of people and blood that we are taking from the people to save lives. And this is the task not only for medicine, but also for governments, for the health volunteers, and then. As we talked, it consists of plasma and cells, and about plasma mainly we will talk today. From ancient time, the philosophers proposed that the main fluids of our blood are phlegm, yellow bile, black bile, and blood. You know that blood in Latin is sanguis, and now you can see the roots of words that we are using in to name the temperaments of the people. But medical terms, put attention, related to blood often begin from the prefix hemato, from the Greek word haima, which means blood. So hematology is a science about blood. Hematotransfusion, it's a transfusion of blood. Mainly, we are using these terms. But some clinics, you know, this is the first temperament. There is an ancient Greek myth about Gorgona Medusa, one of the three sisters of Gorgons. The woman, Gorgons, it's a monster with a woman face and snakes instead of hairs on the head. Her gaze convert to stone all the men that look into her eyes. She was killed by hero Theseus, and then blood that flows from the cutted head of the Medusa was taken by Athene, and she gave this blood to Asclepius. I hope you know that finally Asclepius was taken to the Olymp, and now, not now in ancient time, but now also, it's a symbol of medicine because it was a god of health and medicine. Myth tells that the blood that follows from the left side of the Medusa head brought death, and had blood that follows from right side was taken by Asclepius, and he treated with this blood many people during his life. So even ancient people, they understood that blood is life, but blood can vote for death. Let's discuss the main blood functions. Of course, at first and primary, you all name this function as the most important. Blood transports oxygen from lungs to peripheral tissues. We will discuss this function more detailedly because it is very important. Blood transfers nutrients from gastrointestinal tract to all of our cells. and this function we are naming nourishing. Blood transfers also end products of catabolism, and this function we can name excretory. It means that all blood after this must be filtrated by kidney to excrete water-soluble compounds and by liver to excrete water-insoluble compounds with the bile. We know that this function is also function of liver. Blood transports intermediate metabolites. Integrative function of blood means that tissues can make signals one to another and can exchange the molecules and information. So this function is named integrate. Of course, it delivers hormonal signals to all cells, and this function we can name regulated. Blood helps for the endocrine system regulate tissues that are located in the body far from the endocrine glands. Blood protects from foreign antigens. It means viruses, bacteria, fungi, and all foreign molecules that can come to our blood. And of course, protect from the bleeding and thrombosis. So this function is defense, protective function. Finally, blood participates in maintenance of pH of not of only of itself, but of all of the body, water-salt balance, temperature maintains. So this function we can name homeostatic. And let's discuss red blood cells and their function. At first, we need to manage the metabolic specialities of red blood cells. You know that in maturated erythrocytes, there are no many organelles. From reticulocytes to matured erythrocytes, these cells are losing their organelles, so they are not containing mitochondria. The energy for erythrocytes is supplied only by anaerobic glycolysis. With lactate formation, it can be easily excreted to the plasma and then, can be used for the gluconeogenesis in the 20% of glucose, significantly higher quantity than in other tissues, is metabolized through the pentose phosphate pathway. For what it is necessary, we will see membranes of erythrocytes are very important for the performance of their function, and it is necessary to protect them from the oxidative stress. But the function of erythrocytes is to work with oxygen. So the risk of formation of active form of oxygen is the highest than in other cells. But they are first meeting all bad things that can come to our blood. So we need in the reductive equivalence for the reduction of our different enzymes, molecules that are participating in the reductive systems, cytochromes, coenzymes, and then. So the source of this reductive equivalence is pentose phosphate pathway. Due to this, so many glucose is oxidized because it's an alternative pathway to oxidize glucose. If we are dehydrogenating it, we are oxidizing it. And finally, very important reaction that is present only in red blood cells. This is a formation of 2,3-biphosphoglycerol. Write these reactions. You can see the phosphoglycerate kinase reaction from the glycolytic pathway. In this reaction, normally once 3-diphosphoglycerate was converted to the 3-phosphoglycerate, and this was the first reaction of substrative phosphorylation. You can see that ADP in this reaction is converted to ATP. If you remember, two molecules of bisphosphoglycerate are converted to two molecules of 3-phosphoglycerate, because previously glucose was cutted on 2-phosphatidyls. But by the action of specific enzyme, bisphosphoglycerate mutase, the special molecular 2,3-bisphosphoglycerate can be formed, and it's a very important regulator of function of erythrocytes, we will see later. But of course, there must be pathway how to obtain 3-phosphoglycerate from this molecular, because if energy is in priority, obtaining of energy is in priority, of course, we require in 2 molecules of 3-phosphoglycerate. And for this we have simple hydrolytic enzyme which can cut excessive group in the not correct position in 2,3-diphosphoglycerate. What is necessary to know about these molecules? You can write this. It is very important for the long-term regulation of affinity of hemoglobin to oxygen. This shunt pathway derived from glycolysis from 1,3-diphosphoglycerate, and this mechanism is based on the competition with oxygen for binding site on the beta subunits. Hypoxia stimulates synthesis of 2,3-diphosphoglycerate, and this will improve the release of oxygen from the hemoglobin. So if concentration of oxygen will be decreased, the affinity to phosphoglycerate will be increased also, and this molecule will tell to oxygen, which is tightly bound to hemoglobin, change this strength of interaction and go to the cytosol of the cell. So, oxygen is a major electron acceptor in our body, and we know that this reaction between electrons and oxygen and formation of water after this will finish the process of electron transport chain and formation of potential on the inner membrane of mitochondria, and the follow after follow of protons back to matrix, ATP is produced. This is the process of oxidative phosphorylation. We depends from this process very tightly. CO2 and water as well is a major byproduct energy metabolism. As you remember, of course, CO2 is present in our body in the specific concentration, and this is a result of decarboxylation reaction, but the most very often these reactions are accompanied with oxidative decarboxylation, it means with the oxidation of molecules. So subsequently, one by one, we will take electrons in hydrogen atoms from the organic compounds that contain carbon, oxygen, and hydrogen. So if we will take all hydrogen from the organic molecules, carbon skeleton will be cut by subsequent reaction of the carboxylation to CO2. Gas transport is continuous interchange of CO2 and oxygen between lungs and tissues, and erythrocytes helps in this process. The most important protein of erythrocytes for the transport of oxygen, of course, is hemoglobin. It is so important protein, and it is very strange that part of students cannot describe its structure correctly. When I asking Are all subunits of hemoglobin the same in primary structure, or maybe they all are different? Or big part of students immediately agree with me. Look, please, it's a heterotetramer. 4 peptide subunits are represented by 2 alpha and 2 beta subunits. And beta subunits are the same in primary, secondary structures, and alpha subunits are equal one to another, but beta and alpha subunits are different one from another in primary structure and of course in secondary tertiary structure. This protein has a quaternary structure because more than one polypeptide chain is present here. And hemoglobin is the representative of complex proteins because it contains protoporphyrin rings heme with atom of iron inside of it. Also, look and answer correctly on the question how many hemes and how many atoms of iron each molecule of hemoglobin contains. The conformationally hemoglobin can be in 2 states, which are named R or T state. About R and T state of hemoglobin a little bit later. And now, due to its structure, hemoglobin shows cooperative binding with oxygen. After interaction of one molecule of oxygen with one subunit of hemoglobin, the affinity of next subunit is significantly increased. And this process will be continued after interaction with the second, then third, and finally 4 molecules of oxygen can interact with hemoglobin. To understand this cooperative effect, look please to the curve of saturation of myoglobin and hemoglobin independence from the partial pressure of oxygen. I remind you that myoglobin is also a hemoprotein. It's very similar to beta subunit of hemoglobin, but this is tertiary structured protein because only one polypeptide chain has this structure. This is a protein from the cytosol of our muscles, and its function is to keep oxygen inside of these cells. Myoglobin can interact only with one molecule of oxygen, and at low partial pressure of oxygen, it is nearly completely saturated. For what it is necessary? It means in tissue where partial pressure of oxygen is very low, it is high in lungs, understandable. Myoglobin can keep oxygen as more as it can. Curve of hemoglobin is sigmoid due to cooperative effect. When partial pressure is low, like in tissues, hemoglobin is not completely saturated. It means that oxygen that was taken from the lungs now can diffuse to the tissues. But when partial pressure will be higher, like in lungs, it is completely saturated. So in lungs, due to cooperative effect, hemoglobin has high affinity to oxygen, and when it will go to the tissues, this affinity will be decreased, and it creates the situation when oxygen can diffuse to the peripheral cells. Let's look to the action of enzyme that is present inside of erythrocytes. Carboanhydrase. This enzyme can convert water and carbon dioxide to carbonic acid and bicarbonate ion. And these are very important substances that will regulate affinity of hemoglobin to the oxygen. You know that bicarbonate buffer system is very important to maintain pH, and these ions and carbonic acid is represented in erythrocytes and in plasma in approximately high concentration. So are relaxed conformation of hemoglobin. This is the conformation at which oxygen can easily be bound to hemoglobin. Like in lungs, where concentration of oxygen is at highest quantity, this affinity will be at maximum. And this due to the so-called relaxed R state of hemoglobin, which depends from the pH, from the concentration of these components of the bicarbonate system. Why? You know that proteins are polymers of amino acids, and alpha carboxylic group and alpha amino group, they are coming through the peptide bond, but radicals of amino acids are free and can interact with the solution and one to another. Part of radicals of amino acids are charged, and due to this, proteins are charged molecules. Look to the histidine residues that are charged nearly positive, but really this positive charge will appear on the radical of histidine only at lower pH. You must understand that. A change of pH, a change of concentration of hydrogen, this hydrogen can be accepted by atoms with the part charge like this nitrogen, and total charge will be changed. At lower pH, like in peripheral tissues, this histidine residue will be charged, look, and it will change interaction of this radical with radicals of other molecules. This histidine can form ionic bond. Plus will interact with negatively charged radicals, and all subunits will be connected with these salt bridges, ionic bonds, in more in more compact conformation, and this T state is not loving oxygen. It allows oxygen to go from the subunits of hemoglobin to the peripheral tissues. So this phenomenon is named Bohr effect. It means that pH affects on oxygen binding by hemoglobin. Look how this curve, sigmoid curve, is shifting left or right in dependence of change of pH. This is the pH 7.4, and if it will be more alkaline, it will shift left, and in lungs we can obtain more oxygen. And when pH is changed, like in tissues, high concentration of proton of hydrogen will cause shift of this curve to right. It means a release of oxygen to the tissues. This dependence is named Bohr effect. but also shown that carbon dioxide also influence to this process. Why? Because carbon dioxide can shift the pH when it will come to the erythrocytes. Carbohydrates change it to carbonic acid, which dissociate to hydrogen and bicarbonate ion. So when carbon dioxide is coming, concentration of protons increased, pH decreased, and this will shift our curve to release oxygen. This is named Haldane effect. So look, Haldane effect describes how oxygen depends from affinity of hemoglobin to oxygen depends from carbon dioxide. Bohr effect, how this hemoglobin affinity depends from protons, from pH. And this is mnemonic rule. How to remember this? You can use it. Actually, this is the one process. We describe this here, but from different side of dependence. More often we are talking Bohr effect, but you must know also that there is another point of view on the same process, and sometimes we can meet this Haldane effect. We must understand that this is the one process. So let's write now factors which influence to affinity of hemoglobin to oxygen. Here I'm explaining that right shift means high ability to release, but low ability to bind. So this process, release and bind, it's also a reversible process. And in tissues, site where oxygen is released, what can influence? We did not tell this now, right? That change of temperature is also influence to this affinity. It's understandable because we know that our proteins are pH and temperature labeled. So higher temperature can help to release. Lower pH, Bohr effect, helps to release, and high concentration of 2,3-biphosphorescirate level, because if tissues, tissues all the time existing in the lower partial pressure of oxygen, of course, than lungs, but if it is decreased by some factors, understandable that it's a signal to release more oxygen to compensate the hypoxia that appears. And to finish this discussion, write please 3 ways of carbon dioxide transport. Because from the school we studied that hemoglobin is transported carbon dioxide back from the tissues to the lungs. It's not completely correct because carbaminohemoglobin formation, real interaction with hemoglobin, it's only 10% from the whole transport of carbon dioxide. So the first is bicarbonate formation within red blood cells, carboanhydrase reaction that I shown you, and exchange with chlorine. This is also named hamburger effect when carbon dioxide is coming inside of the erythrocytes. The chlorine will go away. Then, next, the power of this process is carbon dioxide dissolved in blood plasma. There is a part of carbon dioxide that can be dissolved and follow together with blood from tissues to blood. And finally, really formation of bond between carbon dioxide and hemoglobin with amino groups of radicals of amino acids. This carbon dioxide is interacting, and this substance, this connected substance, is named carbaminohemoglobin. We are usually not use amino and mean this substance, hemoglobin interacting with CO2 carb, hemoglobin. Let's talk about forms of hemoglobin that we have or can have in the human body. Part of them absolutely normal. For example, hemoglobin F, which is fetal hemoglobin, and formed in fetus during the development inside of the mother. So this hemoglobin has a specific structure. Two alpha subunits are combined with the specific two gamma subunits. Another gene is expressed and another subunit is synthesized. The property of this hemoglobin is in higher affinity to oxygen. Lungs are not working, air is not coming, so it is necessary to take as more oxygen from mother blood as possible. And this is adaptation for this intrauterine development. Hemoglobin of adults that we discussed, 2 alpha to beta subunits. By this type, 97% of hemoglobin in adults is represented. And you remember, I hope, that when after burning, hemoglobin must be changed to hemoglobin F must be changed to hemoglobin A, and this is accompanied with the hemolysis of erythrocytes. Due to this, physiologically, newborns after 1 or 2, 3 days after life, nearly all can have a hemolytic jaundice with increased level of bilirubin, of indirect, of course, bilirubin. We discussed this, and you must remember that this process is physiological, but sometimes, especially in premaged babies, it can be converted to pathological icterus, so must be under your attention. And 2-3% are represented by the subtype of normal hemoglobin A, it is named hemoglobin A2, the type of subunits instead of beta is delta. See. Hemoglobin of adults can be modified. For example, we have nearly high level of glucose in our blood, and part of hemoglobin can be glycosylated. This glycosylated hemoglobin normally we are not checking, but in case of diabetes, in case of hyperglycemia, it is a very useful marker of long-term hyperglycemia. And we are using it to check, is diabetes compensated enough? It means when long time the patient using insulin for control of hyperglycemia, the measurement of glucose level will be done often, but not so often to check all the time of the day there was specific normal level of glucose, or sometimes it was increased. In this case, the value of glycosylated hemoglobin will be higher than necessary. So we are using it, and you have tasks for this marker. Write please that glycosylated hemoglobin is indicated like hemoglobin IC. Pathological hemoglobins also can appear in our body when some agents will come to the blood. But normally, oxygen can change our hemoglobin to so-called met hemoglobin that contains iron 3 plus instead of iron 2 plus. This can be caused, for example, by uptake of food or water with nitrate or nitrite. In this case, hemoglobin when it is in connection with oxygen, can lose the electron together with molecule of oxygen, and this is active form of oxygen radical that can cause oxidative stress. By special enzyme like superoxide dismutase and then catalase, it can be converted to hydrogen peroxide, and then glutathione peroxidase system enzyme which is combined with the tripeptide glutathione with SH groups on its residue of cysteine in the structure of glutathione, can interact with this peroxide and convert it to water, but in this case it will be oxidized itself. So there is a special enzyme glutathione reductase that will return glutathione for the reduced state, and it can participate in the compensation of the formation of hydrogen peroxide. Glutathione reductase system for the reduction of glutathione use NADPH2. NADPH2 is formed in pentose phosphate pathway by the action, mainly by the action of glucose 6-phosphate dehydrogenase and glucose 6-phosphate is a substance that is oxidized by this enzyme. Then one more dehydrogenase is here, and more portion of NADPH2 will come to the glutathione reductase system, allow for glutathione be reduced. So this is the connection between glycolysis, pentose phosphate pathway, and glutathione reductase system. Our protection from the superoxide radicals. Methemoglobin cannot perform function of normal hemoglobin and sometimes precipitate inside of the erythrocytes. Due to this, in case of methemoglobinemia, significantly increased the cyan that can be visible in the microscope, which is named Heinz bodies. Normally, the concentration of this, the quantity of these Heinz bodies that are observed must not be high, because normally the system must work good. But in oxidant stress that can be caused by infection, by uptake of drugs, oxidative drugs, for example, anti-inflammatory drugs, they are great oxidators, or for example, anti-malaria drugs also can cause this effect. Some products like fava beans will interact with this system, and oxidative stress will be higher than it is possible for this system to relax. And in this case, oxidative stress will lead to hemolysis. Also, hemolysis will be activated if superoxide dismutase and catalase are not working normally. But here you can see that deficiency of glucose 6-phosphate dehydrogenase will also affect production of NADPH2, and all system will lead to the accumulation of superoxide radicals and hydrogen peroxide and hemolysis. I remind you, we talked about this, the deficiency of glucose 6-phosphate dehydrogenase leads to hemolytic anemia. Other forms of pathological hemoglobin you can see here. It's, for example, methemoglobin, carboxyhemoglobin. Look, carboxy, not carb. Carb hemoglobin is normal combined with CO2. During CO2 poisoning in smokers that can obtain this with the smoke, with the quantity of carboxyhemoglobin can be increased. It can be dangerous in high concentration. The connection between CO and hemoglobin is significantly more stronger than with oxygen. And to treat such patients, it is necessary to use oxygen with high pressure. Salt hemoglobin, which is green in color after uptake of sulfonylamides in inadequate quantity. And finally, hemoglobin S, which can be made in blood of patients with sickle cell anemia. Very quickly, let's repeat what defect we have in sickle cell anemia. In this disease, it was the first point mutation, missing mutation that was described clearly, and mechanism of disease was known very far. Only one amino acid change in beta subunits in 6th position. In normal, hemoglobin must be glutamic acid, but due to the change in sequence of nucleotide, look, adenine to thymine, sequence version, valine is placed by the ribosome, and this will lead to all other complications. If you remember, the radical of glutamic acid is negatively charged, in valine hydrophobic. So this also explains why normal hemoglobin changed to sickle cell hemoglobin start to interact one to another, because new hydrophobic site appeared in the beta subunit. And hydrophobic interaction, is necessary to hide one another from what? These hemoglobins molecular weight of such aggregates is significantly higher, and it is aggregate and precipitate on the bottom of the, if there is a bottom in erythrocytes, it can be converted, rotated. Near the membranes, the aggregate, which are named tactoids, will follow up from the, became insoluble and follow down, and it is visible in the electron microscope. Such cells become sickle, visibly sickle, and of course surface is changed, but surface is very important for the interaction with oxygen and following through the blood vessels. So from one point of view, less oxygen can be bound. From another point of view, the flexibility of the membrane is significantly changed, and this will lead to hemolysis. So with polymers, with tactoids of hemoglobin, these cells cannot pass through the blood vessels normally and cannot perform its function. So hypoxia will be complicated with hemolysis, and chronic hemolysis will lead to the early death of these patients. Look to the genetics. It's a recessive gene, so if both of parents are heterozygotes, in 25% of cases, they can obtain son or daughter with this disease. And distribution of the sickle cell anemia is very similar to distribution of malaria in history. And this explains why this mutation is keeping in the population, Mediterranean population, and some Africa areas. Another situation, another type of pathological hemoglobin we can see in thalassemias. In thalassemias, the changes are more stronger. There is a disorder of synthesis of one of the type of chains in hemoglobin, in beta thalassemia, and we have excess of alpha chains. In alpha thalassemia, we have excess of beta chains. These hemoglobins also can perform normally functions and cause hemolytic anemia in these patients, which are accompanied sometimes with changes in the structure of bones. It's necessary to maintain that oxygen released from hemoglobin helps to maintain pH in tissues. Look to the reaction between oxygen and hemoglobin in the lungs. It will lead to the formation of free hydrogen protons. So CO2 is formed from plasmatic bicarbonate and proton released from hemoglobin. Carbon forms proton and carbon dioxide. We saw in tissues forms proton and bicarbonate ion. Proton is bound to the hemoglobin when oxygen is released. So this reaction like Goldberg. Bicarbonate levels of red blood cells, important factor in this. And enzyme carboanhydrase plays a key role, and as I told you, interchange between bicarbonate ion and chloride is named Hamburg character. This checkpoint you can write. And now we will start to discuss acid-base regulation. You must know the most important buffer system of blood, and more powered, of course, is hemoglobin. The concentration of hemoglobin is high in our blood, but this buffer system is combined with the intracellular buffer. If we will talk about plasma, the second place we will put to the proteins. Proteins that have big quantity of carboxylic group and amino group, not only from the N and C end of protein, but also inside of polypeptide chain in radicals of charged amino acids. So they can donate or accept protons independent from their concentration. Due to this, they can be buffers. And the most important plasma inorganic buffer system, this is bicarbonate. We told already how does it work. And last but not least, phosphate buffer, which for blood is not so important, but for example in tissues and in kidney, this system is working with biggest strength. Normally pH of blood must be nearly the range 7.35, 7.45. In different sources this range is a little bit another. Nearly 7. If you will calculate 7.4, it's near the average between this significance. If pH is changed in the lower numbers, we will name this state acidosis. And if it is changed more than 7.45, this we will name alkalosis. Here the significances of pH, which is very dangerous to death, are represented. So really alkalosis and acidosis will be observed if pH changes on so small range. So acidosis and alkalosis will be caused by several reasons, and the most important, the most simple division, it's a division to metabolic and respiratory acidosis and metabolic and respiratory alkalosis. It's not exact according to the causes that will lead to alkalosis and acidosis, but at least this gradation you must know, and must know what reasons will cause one and another, because the tactic of compensation will be different in each of these situations. Respiratory acidosis usually caused by rapid swallow respiration, hypoventilation of lungs, which will cause hypoxia, decreased level of oxygen, and rapid increase acidic equivalent due to the increase of partial pressure of carbon dioxide. Carbon dioxide will be retained by the lungs in case of hyperventilation, and this will lead to the signs of this state. What are causes of respiratory acidosis? It's decreased respiratory stimuli, for example, overdose of some drugs during anesthesia or other situation. Pneumonia, epilepticus, it means something that not allow for lungs to take enough quantity of oxygen and will lead to the retention of carbon dioxide in lungs. Metabolic acidosis will be observed when some acidic equivalents will come to the blood in the great quantity, or when ability of kidney to excrete acids and convert it to base will be decreased. So it can be caused, for example, by ketone bodies in diabetes mellitus when their concentration is not controlled, but also by severe diarrhea when alkaline equivalents we are losing renal value, as we told, when it cannot convert and maintain acid balance shock, and will be accompanied with headache, hyperkalemia, muscle twitching, flushed skin, vomiting, change in action of nerve system, till confusion and coma. Respiratory alkalosis caused oppositely by hyperventilation, anxiety, fear, mechanical ventilation, when patient is treated by doctors very intensively, will lead to the increase of pH due to lower concentration of carbon dioxide, and will be accompanied by seizures, deep rapid breathing, tachycardia, normal or a little bit decreased blood pressure, nausea, vomiting, lethargy, and confusion. And metabolic alkalosis caused sometimes by severe vomiting when acidic equivalents with gastric juice we are losing, excessive suctioning of saliva or also alkaline saliva, diuretic, using excessive bicarbonate uptake during treatment, for example, and this will leads to increase of pH due to increase of bicarbonate ion. This also can be followed by lethargy, with confusion, and previously decreased concentration of potassium, hypokalemia, combined with tremor, muscle cramps, and sometimes compensatory hyperventilation. to compensate metabolic alkalosis by respiratory acidosis. And not big time we have, but I want to represent you the most important blood plasma proteins. So let's quickly repeat what properties our proteins do. This sometimes repeat the functions of blood, because blood is a solution of proteins. Also cells are present, but plasma is a solution of proteins. Which role is, of course, to supply defense function of blood. Fibrinogen is essential for coagulation, but other factors are present. Sometimes you forget it, but we also have anticoagulation system in our blood to prevent thrombosis. Gamma globulins act as antibodies, like adaptive molecules, to show foreign molecules for our immune system. They are not cutting antigens themselves. They are showing them for the immune system. About immunoglobulins we will not talk today. We had a lecture. Today more about transport proteins and different antiproteases. Albumin, alpha globulins, and beta globulins responsible for transport of hormones, enzymes, lipids, and then alpha and beta globulins plays also great transport role to transport metals like iron, for example, in our blood. And role in maintenance of osmotic pressure in blood. I repeat, write this please, that the part of osmotic pressure that is supplied by proteins is named oncotic. And albumin exerts maximum pressure because it is more concentrated protein in our blood. During discussion of this question, all the time you have a problem because you are confusing osmosis process of movement of the ions through the semi-permeable membrane from the zone of high concentration to the zone of low concentration, and osmotic pressure. Osmotic pressure, it's a pressure, hydrostatic pressure, that can be caused by all salt particles. So if we have electrolytes particles, they also participate in osmotic pressure. If we have particles of molecules of proteins, they also will participate in the formation of this osmotic pressure. The level of osmotic pressure is very important because we have cells in our blood. And if osmotic pressure is changed and will be lower outside or higher inside, or higher concentration of salts will be inside of the erythrocytes, water will come inside of the cells and membranes will be broken by this pressure. If we will have high osmotic pressure surrounding our cells, they will shrink. As we told, the most important significance in the formation of oncotic pressure is played by albumin. It's a protein simple, and look, it is a tertiary structure protein because it has only one polypeptide chain. I remind you that this part of one polypeptide chain that are a little bit separately compacted in tertiary structure are named domains, not subunits, domains. So in the structure of albumin, we can see nearly 3 such domains, so-called 3-bone model of albumin, and no non-protein parts. So this is a simple protein, and this is an example of protein in tertiary structure. nearly 60% of proteins is represented by albumin, and primary function is to maintain oncotic pressure and blood pH, but albumin is also transport molecule. What molecules can be transported by albumin? That's right. These are, I remind you, we talked about this during our classes already. It's a long-chain fatty acids from the places of lipolysis, from the peripheral adipose tissue. Usually, albumin transports long-chain fatty acids to the places of their oxidation, like liver, muscles, even. Bilirubin from the all reticular endothelial cells, which is bilirubin is water insoluble, toxic molecule, so it must be transported by albumin to liver cells, where it will be conjugated with glucuronic acid and excreted with the bile. Many ions can be transported by albumin, for example, calcium, zinc. Nearly 40 ions of calcium can be transported by one molecule of albumin. Then there are specified proteins for our steroid hormones, for thyroxine, for our vitamins, but excess of these fully soluble molecules can also interact with albumin. It is nearly all structured in alpha helices and have many hydrophobic sites on its surface. So look, bilirubin, fatty acids, some hormones, medical substances like remedies and antibiotics, they have also hydrophobic parts of their molecules. They can interact by hydrophobic interaction with these sites of albumin. Another important plasma protein is alpha-2 macroglobulin. This is inhibitor of proteinases, activation of fibrinolysis to prevent thrombosis at necessary time, and inactivation of complement components which are proteolytic and can be dangerous for ourselves. This is a function of this antiprotease. Look to the structure, very interesting. The alpha-2 macroglobulins can, by change of conformation, formate binding site with proteolytic enzymes and hide them inside such interesting pockets. One more enzyme in our blood, this is ceruloplasmin. This is ferrooxidase, that is also can interact with the oxygen and helps in transport of iron. It doesn't transport itself, but due to the oxidase activity, iron from the ferritin from the tissues can go to the transferrin, which is interacting only with iron 3+, and the ceruloplasmin is helping in this. This enzyme, this protein, also transport copper, as we told, regulate oxidation, reduction in transport and utilization of iron. Increased concentration of it shows liver damage because it is synthesized in liver, and decreased concentration can be observed in a disease which is named Cornwallis-Wilson disease. It is accompanied with the inhibition of the peripheral tissue with copper. Transferrin, very important protein. Glycoproteins, actually, except of albumin, most of other proteins in our blood are complex and are glycoproteins, combined with oligosaccharide fragments that helps them to perform their function. Glycoprotein with two high affinity binding sites for iron 3 classes. Transferring transports iron between sites of absorption, storage, and utilization. This is not function of ferritin. Be careful, you are confusing very often. Synthesis is stimulated by lack of iron from the body or decreased uptake. Here in table you can see the comparison between these two proteins. Please, I will not put many attention. If you will want, you will read during the consultation. Another important antiproteinase is alpha-1 antitrypsin, which is synthesized in liver and pancreas also. The function of this antiprotease, the key point of action, this is inactivation of neutrophilic elastase. And deficiency of alpha-1 antitrypsin very often is accompanied with emphysema of lungs due to the activation of elastase, which change of elastic properties of the lungs. Haptoglobin, one of the so-called acute phase of inflammation protein. We name this protein when talk about the hemoglobin degradation, when hemolysis of erythrocytes will be not inside of the cells, not inside of reticular endothelial cells, but intravascular. The haptoglobin will go to prevent loss of heme and iron. So haptoglobin can interact with hemoglobin that is coming from the hemolyzed erythrocytes in the lumen of blood vessels. And after this interact with the receptors on the surface of reticular endothelial cells, can be taken inside of the cell, where then protein part will be taken for degradation and conversion to free amino acids, and heme will be taken separately. Hemoglobin after this will be converted to globin part and bilirubin, then bilirubin, and then pigment exchange. So this prevent losing of heme and iron from our blood, but also haptoglobin is combined to the immune reactions, and receptors is on the phagocytes, on the dendrit cells. So this is a system of interleukin 6 also combined with inflammation. You must remember that concentration of haptoglobin is increased in inflammatory disease and decreased in case of hemolysis, because most of the haptoglobin will work and be inside of the reticular endothelial cells with its hemoglobin. Another, the most important protein from this group, acute immune phase of inflammation, is C-reactive protein. Why it is named C? Because at first it was identified as a substance from the blood serum of the patient with acute inflammation of that was caused by pneumococcus, and it was interact with the capsular polysaccharide. This capsular polysaccharide was named C polysaccharide, and due to this protein obtained its C-reactive name. The function of this protein are very wide, and you can see that it supports monocytes going to the intra-arterial wall, induce production of adhesion molecules, interact with production of nitrogen oxide, induces the special mediators of inflammation expression, mediates low-density lipoproteins and cholesterol, one of the trigger of their oxidation, so involved to the pathogenesis of many things like atherosclerosis, like degradation of endothelium, promotes endothelial dysfunctions and induce complement activation. All of these reactions are necessary for the fighting with infections, with the bad things in our blood, but sometimes they can be go under the control, and high concentration of C-reactive protein, it's a sign that you need to control. Additionally, the processes that are in the patient's organism, so this helps to monitor disease progress. In many diseases, we have recommendations at what level of C-reactive proteins we need to use some drugs to help the patient. And fibrinogen, of course, the function is blood clotting. This synthesized in liver. Most of represented today proteins are synthesized in liver, and due to this liver disease, this is one of the reason for development of hyperproteinemia. We will tell this. To study blood proteins, we are using many methods, but at least about electrophoresis, we need to talk more detailable. Electrophoresis is a movement of charged particles with the constant electric fields. As we mentioned, proteins are charged molecules due to the radicals of amino acids that can accept or leave protons. If we will create constant electric field and put into the buffer solutions piece of paper, this coarse chromatographic paper, we can put the spot of sample, for example, blood serum or blood plasma, if we added something against blood protein, and separate proteins independent of their charge. Positive, dependence from the pH, proteins will be charged specifically, and positively charged proteins will go to the cathode, negatively charged to the anode. So this is the example how the paper and gel electrophoresis we can make in horizontal. By this method, we can separate on the paper, for example, or on the agar gel proteins of blood to 5 fractions. The highest quantity, of course, albumin. Then we can see fractions that are named alpha 1, alpha 2, beta, and gamma globulins. And we know now that, for example, alpha 1 antitrypsin or transcartin, which is necessary to transport cortisol and other steroid hormones, or for example tyrosine binding globulins, they migrate in with alpha 1 globulins. But haptoglobin, alpha 2 macroglobulin, and ceruloplasmin, they are present in alpha 2 fraction. Due to this, you can see alpha 1, alpha 2. Beta globulins represented by transferrin and beta, so-called fraction of beta lipoproteins, and gamma fraction is represented mainly by immunoglobulins, by our antibodies. Against all of these proteins, immunoglobulins are not synthesized in liver, they are synthesized mainly in site of red bone marrow by beta cells, and due to their different primary structure, they have different charge and separated and formate so light curve, no significantly separated spots or lines. We can do also gel electrophoresis in polyacrylamide gel. it is possible to do simple electrophoresis, or if we will neutralize the charge of molecules, here we can separate them even by molecular weight, because if we will neutralize, we'll add, for example, some substances that will neutralize the charge, all proteins will move only on dependence of their size. By gel electrophoresis, by polyacrylamide gel, due to the specific structure, we can obtain significantly more reactions on the picture after staining all the separated proteins, and even look what is the difference of the movements of actin, tropomyosin, myosin, which are very important proteins that it is possible to investigate. Markers, it means at the specific place we will put polypeptides with known molecular weight. It allows us to determine molecular weight of different proteins. Electrophoresis is used in diagnostic of many diseases, and here you must write the definitions for the disorders of quantity of proteins in our blood serum, or disorders in the fraction. This is hyperproteinemia, hyperproteinemia, and dysproteinemia. Understandable that hyperproteinemia, this is decreased quantity, total quantity of proteins. Actually, here our norm in our country, we are representing 65 to 85 grams per liter. Yeah, 60 to 80. In our MCQs, be careful, there will be 65 to 85. So hyperproteinemia, it's a decreased total quantity of protein, hyperproteinemia, increased, and disorder between fractions, it means when one fraction will be lower but other fractions will be higher, it means in percentage, is named dysproteinemia. It's necessary to explain that hyper and hypoproteinemia can be absolute and relative. To explain this, look to these two glasses with water and imagine that we put the same quantity of substance, 5 grams of sodium chloride to each of these glasses. The quantity of sodium chloride in both glasses will be the same, 5 grams, but the concentration, of course, here will be significantly higher. I think that's 3 times higher than here. So our blood is also solution, the volume of blood in which can be changed in different situations. In this case, we will talk about relative change of total quantity. And if this quantity will be changed really, increased production or increased loss of protein without changes of volume of water, it will be absolute. So, hyperproteinemia, relative, absolutely understandable, loss of water, dehydration, especially hyposmotic dehydration will lead to the relative hyperproteinemia. Absolute hyperproteinemia is possible when production of proteins is increased. Normally, albumin production not exceeds 85 grams per liter. It's not possible, no possibilities for liver to synthesize more albumin. More often, this is due to globulins. As we told, some of globulins are proteins which are signs of inflammatory. Increased activity of proteases, increased production of antiproteases will be as an answer. Increased hemolysis, increased production of haptoglobin will be answer. So, different inflammatory disease leads to the increased quantity of alpha 1, alpha 2, and beta globulins, and infections or interactions or appearance of many foreign antigens, irritation of the immune system will lead to the overproduction of gamma globulins, of antibodies. So in this case, we will have absolute hyperproteinemia. Absolute hypoproteinemia can be observed if uptake of proteins, of amino acids from which these proteins will be synthesized, will be significantly decreased. Starvation or protein absence in diet or loss of protein will be. As we told, liver diseases will significantly decrease albumin production and influence to the production of alpha beta globulins. Like cirrhosis, severe hepatitis, and loss of protein can be, of course, in kidney. In nephrotic syndrome, when at first selectively only albumin will be lost, and then unselectively in the severe cases, all proteins of our blood serum can go to the urine, and this proteinuria can reach significant values. And, of course, can be observed relative hypoproteinemia. Put more water into the blood, so water intoxication or some processes, inflammatory processes in edemas, which will lead to the coming of water inside of the blood stream, will lead to the relative hypoproteinemia. I want to fix your attention very quickly on one of the type of absolute hyperproteinemia that is very interesting, and we are studying this type of absolute hyperproteinemia, these diseases that lead to it, on our department. It's one of the direction of our scientific work. This is overproduction of gamma globulins, but not polyclonal. Professor Petov, I hope, explained to you the difference between monoclonal immunoglobulins and polyclonal. We have normally polyclonal, and due to this, no peaks here. And in case of monoclonal gammopathias, it's a dysproteinemia. The appearance of the specific proteins in gamma fraction we will see. There is a group of diseases which are named paraproteinemic hemoblastosis or monoclonal gammopathias. This is a group of malignant tumors from the cells of B lymphocytic series synthesizing and secreting immunoglobulins or their fragments which are named paraproteins. If tumor will appear from the beta cells that is already differentiated till the secretion of immunoglobulins, the daughter cells will be absolutely the same with mother cells. And pool of this clone of these cells will start to produce great quantity of one type of immunoglobulin, one primary structure, one charge, so one movemental abilities in electrophoresis. These tumors, for example, multiply myeloma, they are located in red bone marrow, and due to this, in patients with such tumors, during the X-ray examination of the plain bones, it is possible to find such a circulating points, circles of disintegration of bone tissues. It's very characteristic symptom for these diseases. The most famous is myeloma, multiple myeloma. In electrophoresis, this is the example of gel electrophoresis of 3 different blood serums. In blood serum of healthy people, we will see gamma fraction as very thinly, not intensively colorated fraction, because they are polyclonal only, and movement of each type of immunoglobulins is different. But in case of presence of big quantity of the absolutely similar molecules, they will be visible as a spot, or if it will be line electrophoresis, paper electrophoresis, will be very intensive line to one place. Localization can be a different place of electrophoregram due to the different properties of paraproteins. It depends from the cell that start to produce them. Everything that will be in the blood serum after precipitation of protein, it means except of protein, is named residual nitrogen. I told about the residual nitrogen on my lecture about urea cycle, but who did not write this lecture, please write now that all non-protein blood nitrogen is named residual, remaining after removal of blood plasma protein. And the most important component of residual nitrogen is urea. Other components are represented by amino acids, uric acid. Uric acid is a final product of urine nucleotide degradation. Creatinine, that is formed after usage of creatine phosphate by our muscles. Small quantity of ammonia, which can be excreted, not big, but can be, indicum, and other nitrogen-containing compounds like glutathione, bilirubin, other non-protein compounds. Normal residual nitrogen content in blood serum is from 14.3 to 25.0 millimole per liter. I remind you that changes, increased quantity of residues nitrogen in blood is named azotemia, and it can be separated to two important types. This is ammoniemia, increased quantity of ammonia on the base of decreased urea, and uremia, when it's significantly increased, especially urea. In simple, ammoniemia can be in case of enzymopathies of ornithine cycle or liver failure, when liver cannot synthesize urea from ammonia. Only liver is doing this, so this is a liver problem. Exactly. And uremia is more often due to the hyperproduction of ammonia by the peripheral cells, because liver can increase its power to synthesize urea, but more tragic situation if this is renal failure, because urea must be excreted by kidney with urine. There are many other regulative systems in our blood. Regulation of glucose you discussed during the lecture about hormones, calcium level, for example, also with calcitonin, parathyroid hormone, and vitamin D here is represented. So we can talk about the system of regulation of water balance and blood pressure, mainly renin-angiotensin system and our hormones, antidiuretic and mineralocorticoids. But this regulative system you already discussed the specific topics on the lessons and lectures. So today I will finish my lecture. Thank you very much, and be full of good blood. Be happy. Goodbye.